Hello and welcome to this webinar, which is brought to you by London Vet Specialists, part of the Linnaeus Group. And my name is David. I am the anaesthetist at London Vet Specialists, and today we are going to speak about anaesthetising the older veterinary patient. It's a situation which I think causes anxiety amongst a lot of vets and nurses in general practice, and hopefully today we will discuss are they really at a much greater risk? Does that preclude anaesthetising them? And what are they likely to suffer from? How can we spot this, and how can we treat it to try and make them the anaesthetic as safe as possible? So a sort of outline for the webinar today. These will all be spoken intermittently as we come across problems. It's not necessarily linear, but first of all, we'll look at assessing and evaluating the risk of morbidity and mortality in veterinary anaesthesia. We will have a look at the physiology of aging, so how the body changes as the animal gets older, and what impact that changing physiology is going to have on general anaesthetic management, and some troubleshooting tips as to how we can overcome these problems. So first of all, just a couple of definitions. What is a geriatric veterinary patient? In human medicine, they define a geriatric as a person who has lived greater than 75% of their expected lifespan. So in humans, this is going to be around 60 years of age, but in veterinary species, this will vary depending on the animal that you're talking about. For example, a cat, 75% of its lifespan might be 14 years, whereas for a very large dog, such as a Great Dane, they may already be considered geriatric at 6 years of age. So there's quite a variety, or quite a variation in what is a geriatric, even within single species, when we talk about veterinary anaesthesia. The second point to discuss is it too risky? Well, what is too risky? And that's going to depend on what the owner, the vet, considers to be too risky, their sort of tolerance of risk, and also on the procedural aim. So whereby a life-changing operation to prevent suffering or pain may be deemed not too risky. If it is mild gingivitis, then maybe anaesthetising the geriatric patient is considered a little bit too risky if the overall outcome is just to remove calculus from the teeth. So it is going to be somewhat subjective, but can we make it any less subjective? First of all, I think it's helpful to try and make things less subjective. So there are a couple of systems that we can use in veterinary medicine to try and become more objective. The first one, which you may be using currently, is to assign an ASA grade to the patient. So this is a scaling system that was designed by the American Society of Anesthesiologists, and it's been modified for our veterinary patients. It ranges from 1 to 5, 1 being a perfectly healthy patient, and you can see on the screen that as disease becomes more and more severe and inhibiting normal function of the animal, the scale increases from 1 up to 5, which is a moribund patient that is not expected to survive without the procedure. Additionally, an E for emergency can be added to any of these cases if it is not a planned procedure. So veterinary literature, unfortunately, in many areas is a little bit sparse, certainly when you compare it to human literature, but there have been several studies which have looked at different risk factors for perioperative morbidity and mortality. And probably the biggest one of these is this study here. It was quite a while ago now, 2008, by David BROADBELT and his team, in which they identified a number of factors. It's the largest study in the veterinary literature, so it's usually the one that we go to refer to. And in BROADBELT's study, he did isolate certain factors which were thought or which were shown to increase anaesthetic morbidity and mortality, and they included an increase in ASA status, extremes of patient size, so very small and very large patients, whether the procedure was an emergency procedure rather than an elective procedure, and age was identified. in dogs as to increase the risk of perioperative morbidity and mortality. Other studies have not identified this as a risk factor, but that's likely due to differences in the methodology used by the authors of those papers. So it seems that there may be some increase in risk to the patient. So let's go through what happens to the body as it ages, so that we can understand what problems that animal is likely to encounter under anaesthesia and what we can do to help them. So we'll run through the main body systems one by one. First of all, the cardiovascular system. So thinking about the normal cardiovascular physiology, its function is to, of course, to deliver oxygen and nutrients to the tissues, to take the oxygen from the lungs and deliver it all around the body, and also to remove any waste products from the tissues and transport those back to the lungs in the case of carbon dioxide, or to the kidneys for excretion. The relevant anatomy which allows the cardiovascular system to perform these functions is that it should consist of an efficient pump, so the heart, and also a dynamic and responsive vasculature, which is your blood vessels, arteries and veins. In addition, hemoglobin is important for carrying oxygen around the body. So these three main anatomical features allow the cardiovascular to do its job well. Unfortunately, as we age, the heart becomes less efficient. So there is some fibrosis of the myocardial fibers, and this can lead to a variety of problems. The first being reduced contractility of the heart, so negative inotropic effect, simply because the muscular tissue is replaced with fibrous tissue, which is not going to contract. And this reduction in contractility is going to reduce the stroke volume. Additionally, fibrous tissue is not particularly elastic, so we have a reduction in relaxation of the heart, or decreased lusitropy. And the consequence of that is that the heart is less able to fill, even if you have a long diastolic period with good venous return to the heart is not able to relax and to take as much blood as what it would have in youth. So this reduced contractility is a dysfunction of systole, and we also have this reduced filling, which is a diastolic dysfunction. Finally, if the fibrosis occurs within the conducting pathways of the heart, so the electrical conducting pathways, this may predispose the animal to an increased risk of arrhythmia. Moving away from the heart, we said that we wanted a dynamic vasculature that's able to instantly compensate for changes in stroke volume. But actually, older animals have a reduced sensitivity in their baroreceptors, so they're less able to fine-tune their vascular tone and maintain a steady blood pressure. And also, when we are trying to help them with drug support under anaesthesia, they may have reduced responsiveness to those supportive drugs. Finally, aging animals have been shown to have a reduced PAT cell volume. So a reduction in the PAT cell volume is going to mean less hemoglobin to carry that oxygen around. So several of these changes are going to predispose the animal to hypotension, low blood pressure. So the definition of hypotension will vary depending on which text that you look at, but it's going to be somewhere around a mean arterial pressure of less than 60 or 65 millimeters of mercury. There are several causes of hypotension. We will go through each of these and try and come up with a plan on how we're going to manage that, or what is the best way to manage that for this individual patient. One of the first, or the main reasons for hypotension may be hypovolemia. This might be either absolute, so due to fluid loss, or ongoing dehydration, or it might be a relative hypovolemia. So if you have a vascular system which suddenly becomes very vasodilated, it has a much larger volume, but the same amount of blood is within that large space. So this can be a relative hypovolemia. Other causes of hypotension can be a reduction in cardiac output, or a decrease in vascular resistance. So again, excessive vasodilation. As a consequence of hypotension, We may have reduced perfusion pressures, so this is a pressure that's pushing the blood into each organ system. And with that reduced perfusion pressure, you're going to have reduced tissue perfusion, reduced oxygen delivery to those tissues, and therefore tissue hypoxia may occur. I think when you're treating hypotension, it's always really important to have this sort of infographic in your mind, because it gives you a very logical way on how to approach a decrease in mean arterial pressure. The variables highlighted in green are sort of standalone features, whereas the blacks are composed of more than one feature. Whenever I come across hypotension in an anaesthetized patient, the first thing should always be to assess anaesthetic depth, because we've put them in this situation that has made them hypotensive. So if we can back off with the amount of drugs that we're giving them, we might be able to get them into a more normal range of blood pressure, and that's going to have the least side effects because we're taking drugs away. It's better than adding in additional drugs which may help the situation, but they may in themselves cause side effects. So I always look at the anaesthetic depth first and reduce the amount of volatile agent that you're giving if appropriate. I think the next best thing to look at is the heart rate, because this is a easily identifiable figure. You look on your monitor or you count the beats per minute and you have an objective parameter. So if the heart rate is abnormally low and you have hypotension, I would usually try to increase the heart rate before thinking about anything like giving a bolus of fluids, because it can be very difficult to assess whether that animal needs those fluids. There's not really a parameter that we routinely measure, whereas for heart rate, it's a number and it's easily identified. So if you have a low heart rate and hypotension, I would usually treat that with an anticholinergic agent, such as atropine or glycopyrrolate. But if the heart rate is normal and you have hypotension, then we have to move on to the next step. So the three remaining factors are going to be preload, so that's the amount of blood filling the ventricle before systole, the contractility, so how forcefully the heart contracts, and the systemic vascular resistance. So again, all of these factors are quite difficult to accurately assess, and we may look at things like the capillary refill time. Sometimes if the systemic vascular resistance is very low, then it will be better. The colour will come back faster, but again, they're quite subjective. So of the next, you kind of have to use clinical reasoning next to decide, is this patient likely to be hypovolemic? Have they been starved overnight? Have they been in the hospital? They're stressed, they've not been drinking, in which case fluid therapy might be a reasonable first step. And you can always give a small bolus and reassess, so maybe 5 ml per kilo, and reassess if it's made any difference. If it's not making any difference, then we maybe need to look elsewhere. With contractility and systemic vascular resistance, we can improve these parameters by using inotropic drugs or vasopressor drugs, respectively. So yes, this is just to recap what I was saying there. So we have, first of all, decrease anaesthetic depth if possible. Treat any bradycardia with anticholinergics. If you suspect that the heart is not contracting very well, maybe the animal has a history of DCM, so dilated cardiomyopathy. This is a disease of systole. Then you can give supportive drugs such as dobutamine, perhaps, which is a positive inotrope. And if you suspect that they have a reduced preload, then a fluid bolus might be indicated. Moving on to the respiratory system. Again, we'll look at the normal function, or is to oxygenate the blood and to remove carbon dioxide, amongst other features, but these are the main ones that we're concerned about in the anaesthetic period. And in order to perform this function, they rely on an anatomy which includes an extremely large surface area and a very thin alveolar membrane which allows efficient gas exchange. And the lung is also relies on its massive perfusion in order to perform these tasks. It's the only organ to receive 100% of cardiac output. This graph demonstrates the different lung volumes and capacities that we can consider, but the first one is tidal volume. So this is normal quiet breathing, and that's the one that we would normally be effective in getting rid of carbon dioxide and providing sufficient oxygenation of the blood. But the functional residual capacity, which is a little bit further along in the on the graph on the bottom, is the amount of gas which remains within the lung at the end of a normal exhalation. Now, this acts almost as a reservoir for oxygen. Even in the case where the patient becomes apneic, there is some air, which may be oxygen rich if you have pre-oxygenated, that acts as a store and can continue to oxygenate the blood even during a short period of apnea, which may happen during induction. So age-related respiratory changes include the fact that smaller airways have a greater tendency to collapse in older animals, which may reduce our functional residual capacity, so reduce this air store and make the animal less tolerant of apnea. The lungs also become less elastic, so they become more difficult to expand in excess. So to top up your normal tidal volume, you may take deeper breaths, but if the lung is less elastic, this ability may be reduced. And this loss of elasticity reduces the pulmonary compliance, and also the actual thoracic cage becomes less compliant with aging. And when you combine that with a reduction in muscle strength that occurs with aging, the animal is having to work harder just to take that breath, and they may, in the end, begin to tire of that and go into respiratory fatigue or failure. In addition to these changes, no one body system is completely isolated. So if we consider the changes that we discussed with the cardiovascular system together with the respiratory system, any reduction in cardiac function may predispose to what we call a perfusion ventilation mismatch. So if you consider the individual alveolus, we would like the blood flow and the ventilation rate to be equal so that gas exchange can occur at an even rate. However, within the lung, there may be areas which have very good perfusion, but very poor ventilation. Good perfusion and poor ventilation means that blood is passing through the lung without taking up any oxygen, and this is what we would call a pulmonary shunt, and this can lead to hypoxemia, so a low level of oxygen in the blood. Conversely, an area of good ventilation where there is not a great blood supply, maybe due to very low blood pressure, means that gas ventilating the lung is being wasted because none of it is being taken up by the blood, and this is what we call dead space ventilation. Other things which may predispose to hypoxemia include increased risk of aspiration pneumonia, and there are a couple of reasons why that might be the case in older animals, including a decrease in protective laryngeal reflexes, and it's been shown that older animals are more likely to regurgitate in the perioperative period. So this is very important, particularly around induction and recovery, where you may consider to perhaps have a slightly later extubation than what you normally would, because these laryngeal reflexes aren't as strong as they would be in the young animal. So thinking about hypoxemia, again, absolute definitions will vary depending on the text that you use, but commonly that would be referred to as a PaO2 of less than 80 millimeters of mercury, which corresponds to a saturation on your pulse oximeter of 94%. And if we think of the potential causes of hypoxemia, they can be hypoventilation, so where the animal is too tired to adequately get rid of carbon dioxide. This carbon dioxide will dilute the oxygen within the alveolus and may cause hypoxemia. We discussed ventilation perfusion mismatches just on the last slide, so where the amount of ventilation does not equal the amount of perfusion in that particular area of lung. And also we have the possibility of diffusion impairment. So we said that one of the anatomical features of the lung which allows good gas exchange is an extremely thin barrier between the alveolus and the artery. If that is thickened for any reason, for example by edema or chronic inflammatory conditions, then we may struggle to oxygenate the blood in these cases. And finally, hypoxic gas mixture is the final cause of hypoxemia, but that's unlikely to happen if your equipment is working well. And as a result of hypoxemia, we have reduced delivery of oxygen to the tissues, which may result in tissue hypoxia, which in severe cases will cause cell death. Hypercapnia or hypoventilation is the second measured parameter that we might see in our geriatric patients that can have a definition of an arterial CO2 of greater than 45 millimeters of mercury. And when we're measuring with capnography, we're using the end-tidal CO2 as a substitute for the arterial carbon dioxide, which should match quite closely in the small domestic species. Reasons for hypercapnia may be hypoventilation, so failure to get rid of the normal amount of carbon dioxide, or it may be due to an increased production of carbon dioxide. The first one, hypoventilation, is by far the more common cause. Consequences of this hypercapnia, so increased carbon dioxide levels in the blood, may be that it increases sympathetic nervous system stimulation, which on one hand can sometimes be a little bit helpful under anesthesia because it may promote increased heart rate, increased contractility of the heart. However, it will also increase risk of arrhythmia, which is obviously detrimental to the patient. So a mild hypercapnia may cause this mild increase in sympathetic nervous system stimulation. But if that progresses to become a more moderate or marked hypercapnia, we start to lose that beneficial effect, and it will cause a significant respiratory acidosis and directly depress the ability of the heart to contract. It also causes vasodilation, which may reduce the amount of blood which is returning to the heart if the blood is all stuck within these venous capillary beds. So for treatment of hypoxemia, again, we just think of our underlying causes, which we discussed on the previous slide. So hypoventilatory, if they're not getting rid of enough CO2. Luckily, when they're anesthetized, we have the ability to ventilate for them. So the treatment of hypoventilatory hypoxemia would be mechanical ventilation or IPPV by hand. And this will also treat hypercapnia. It's also the treatment for hypercapnia, sorry. If you consider that if you suspect that maybe you have a ventilation perfusion mismatch, then we have two strategies depending on whether it's dead space ventilation or shunt that we're considering. If it's shunt, so good blood supply passing through poorly aerated areas of lung, we can consider an alveolar recruitment maneuver, which involves closing the APL valve and holding positive pressure within the lungs for a period of time to try and encourage those non-ventilated areas of lungs to open again and allow them to become ventilated. So you have to be careful when doing this, that you don't exert too much pressure. But if you close the APL valve and just hold a steady, gentle pressure within the lung for 5-10 seconds and then open the APL valve again, this may improve the alveolar ventilation. If the other situation is true, that we have good ventilation but poor perfusion, we may try to improve pulmonary perfusion, and that's likely to be caused initially by hypotension. So if we can go back to the previous slide and see if we can improve the blood pressure to improve the blood flow to these well-aerated areas of lung. If you suspect diffusion impairment is the cause of your hypoxemia, then that needs treatment of the underlying cause. So again, in the case of pulmonary edema, that may be some diuretic drugs. And finally, if you have insufficient inspired oxygen fraction, then there's likely to be a machine error, and you should change to an anesthetic machine that is functioning normally. Moving on to the renal system. And the kidney has many functions in the normal day-to-day life of an animal. Some of those include fluid and electrolyte balance, the maintenance of a steady acid-base balance, produces hormones such as erythropoietin, which is important for red blood cell production, and also it is involved in the metabolism and excretion of many drugs. The anatomy, which allows the kidney to perform these functions, include the fact that it's made up of millions and millions of functional units or nephrons. Each of these nephrons has a specialized endothelium and basement membrane, which acts as a filter for blood, allowing waste products to pass through whilst keeping a hold of valuable proteins, for example, within the blood. And they too also have a generous blood supply, receiving around 20% of the cardiac output. So this slide demonstrates the reason why with kidney patients we're very worried about keeping the blood pressure normal. It's worth saying that it shouldn't just be for kidney patients, because we may have loss of nephrons if we have significant hypotension, and any loss of nephrons to any patient is important. Of course, for patients that are already suffering from kidney disease, it's more critical, but we really should try to maintain the blood pressure to maintain GFR and renal blood flow in any patient that we're anesthetizing. And the reason that we choose something around 60, 65, 70 as a lower limit for the tolerated blood pressure under anesthesia is because many of the vital organ systems, and including the kidney, they have this ability to auto-regulate their blood flow over a range of blood pressures. So again, this graph, the absolute figures will vary depending on which text you use, but renal blood flow is maintained at a steady level between the ranges of a mean arterial range of 70 to 170 millimeters of mercury. But if you drop below that level, then blood flow becomes pressure dependent. So the more significant the hypovolemia, the more significant the hypotension, the less blood flow to the kidney and the higher the risk of nephron loss. So age-related changes within the kidney, as I say, we start with these millions and millions of nephrons, but any insult to the kidney may result in loss of some of those, because it requires 60–70% of nephron loss before we see changes in our common biochemical markers such as urea and creatinine. And in fact, it's estimated that between 15 and 20% of geriatric cats and dogs will have some degree of renal insufficiency, whether that is not detected on the blood tests that we have available at the moment, whether it's detected earlier by some biomarkers rather than the urea and creatinine. It's not important, but the fact is that a significant portion of those older animals will already have significant nephron loss, so it's important for us to try and keep the ones that we have without causing them damage. But because they have some degree of renal insufficiency, they may have poorer fluid balance control. So during perioperative fasting, they may be more prone to dehydration if they're not able to adequately concentrate their urine. If they are more advanced in their renal disease, and we do have an azotemia, then there are some effects of urea which are relevant for anesthesia, including that an elevated urea affects the metabolism of many drugs and may reduce the toxic thresholds, predisposing them to side effects of the anesthetic drugs. Elevated urea also affects albumin's ability to bind drugs, which may cause a more exaggerated response in that animal compared to the same dose in a normal animal. And again, we may see a more pronounced effect because elevated urea may increase the permeability of the blood-brain barrier, so drugs are moving more easily from the circulation into the central nervous system. Moving on to the hepatic system, again, the liver has many functions, including drug and toxin metabolism. This is one of the first ones we generally think of, but it's also responsible for synthesis of a lot of proteins, including albumin, synthesis of glucose to maintain steady blood glucose levels, and it produces the clotting factors for hemostasis. Again, the relevant anatomy, which supports these functions, includes that it's a very large organ, it receives a lot of blood supply, and it does have a good functional reserve. So significant functional units of the liver have to be lost before we will see any clinical change in that animal. So if the animal's liver is not working as efficiently as it should, what impact is that going to have on anesthetic management? We may, as the animal gets older, they do lose hepatic mass, so they have fewer numbers of hepatic enzymes to deal with drugs, and blood flow is reduced to the liver in older age, so the drugs that we do give the animal may circulate for longer before they are removed or broken down by the liver. So we may see prolonged drug action and increased duration of clearance of these drugs. We don't have very many prodrugs in veterinary anesthesia, but prodrugs are drugs which do not become active until they are partially metabolized. So if we were to have many prodrugs, we may find that they're not very effective because the liver is breaking them down into the active form more slowly. If the liver insult is very severe, you may have reduced protein synthesis, which might cause hypoproteinemia, which then in turn may result in peripheral edema or exaggerated drug effects due to reduced protein binding. The animal may be predisposed to hypoglycemia because glucose production is impaired, and if the production of clotting factors is affected, again, this tends to happen when the liver is quite severely affected. This may lead to coagulation defects. Next, we'll consider the neurological system. So with age, the neurological system changes in that the brain mass becomes less as well. So we have fewer neurons. They may have reduced neurotransmitter availability. So generally the brain is quieter, and there are not as many neurons firing. And in respect to anesthesia, this means that they may have a more pronounced effect to the same drug dose. So the amount of volatile agent in humans, the amount of volatile agent required to maintain anesthesia is reduced with older patients. And it's also important to remember that when you're inducing anesthesia, again, considering more than one body system together, if you have a reduction in your cardiac output, it's going to take longer for that drug to go from the cephalic vein to the brain. So you need to consider maybe giving your drugs over a longer period of time and assessing whether you have managed to induce with less of the drug. We'll just quickly go through a couple of other body systems which may change. Thermoregulatory control may be reduced, predisposing the animal to hypothermia, which is a common complication of general anesthesia. And also the way that the body is made up, so it's muscle versus fat composition, may have some effects on pharmacodynamic alterations. So hypothermia, as I say, is a very common complication of veterinary anesthesia. It can be defined with these ranges depending again on the text that you use for reference. And the incidence in one retrospective paper was 83%, so a huge number of our patients recover with some degree of hypothermia. And that comes with a lot of consequences, which I'll go through on the next slide, during anesthesia. But one of the main considerations is that if the animal is cold, they're going to shiver in the recovery, and that shivering can actually increase the oxygen demand by up to 300%. So if we think that we've got an animal that's already old, their ventilation and respiratory system is not in tip-top form, and we're then causing them to shiver and increase their oxygen demand, that's really predisposing them to tissue hypoxia because they're going to use up that oxygen very quickly. And older animals are more likely to develop hypothermia because of their body composition. So they have less muscle mass with a lower metabolic rate, so there's less heat being generated, and they also can be more thin-skinned and have less fat cover, so they're not very well insulated, and heat loss may be increased. This is just a curve to show how the core body temperature changes. So within the first 30 minutes to an hour, there is a massive drop in core body temperature. And this occurs because normally to maintain our core body temperature, we have a sort of basal tone of vasoconstriction, which maintains our body core at a higher temperature than our periphery. So our periphery is usually a couple of degrees colder than our core. But when we give a vasodilating drug, we lose this basal tone, and heat from the core moves out to the periphery and starts to warm the periphery. So it doesn't necessarily change the total body heat energy, but that temperature or heat is redistributed into the periphery and can cause a very quick and very marked decrease in core body temperature. Phase 2, the linear core decline, is when heat loss exceeds heat production. And core 3 is later on in the procedure when that starts to flatten off, and hopefully we can regain some ground and warm our patient up. Some consequences of hypothermia, there are many. I'll just run through these quickly, but every body system generally is affected by these abnormal body temperatures. So we may see both tachycardia and bradycardia depending on the degree of hypothermia, and myocardial contractility is reduced, and therefore cardiac output and blood pressure may also be reduced. Increased risk of arrhythmias again in hypothermic patients. The muscle is weaker, so may lead to hypoventilation and problems with hypercapnia and hypoxaemia. Blood flow to the kidney and liver is reduced, and we said that happens already in an older patient, so add on hypothermia and we may have significant reduction in blood flow to these organs. Blood flow to the brain is reduced. It may delay the recovery from anesthesia and cause a more delirious recovery where the animal is fighting. It causes the animal to be more irritable and confused. And actually in humans, the most commonly reported complaint following a surgical procedure is, if they have been hypothermic, that this is an extremely uncomfortable state, like a bone-chilling cold, and they report that as their major complication even over surgical pain. In the blood, hypothermia may increase blood viscosity, so the blood is thicker. The heart is having to work harder to pump that thicker blood around, and the heart is already, again, may not be in its best shape. It may cause coagulation defects, so increased risk of surgical bleeding. And from an immunological point of view, the immune system is impaired, and that may increase the risk of post-operative wound infections. And there is even some evidence that hypothermia may increase the rate of metastasis of neoplastic diseases. So how can we prevent this hypothermia? And there are many techniques, some of which are more effective than others, but the idea behind pre-warming the patient is to avoid or at least reduce that very sudden core body temperature drop that we saw on the graph a couple of slides ago. So if we can warm the periphery, when we lose the vasoconstrictive tone that keeps the heat within the core, if the periphery is already warmer, then we have less heat loss because there's less cold peripheral tissue to warm up. Where possible, we should try and use rebreathing anesthetic circuits such as the circle system. And when we do that, we should try to keep the flow as low as possible for many reasons, but basically the lower your flow, the more you're recycling that air, and it's going to become more and more gradually warm. Some practices may use these heat and moisture exchangers, which is shown in the picture to the right, and they may be effective in reducing heat loss, although the clinical studies that have been performed in veterinary medicine seem to reveal that they don't make a huge amount of difference. Heat lost from the airway is generally minimal anyway. It's probably less than 10%. There are much more significant reasons for heat loss, including radiative heat loss. So when you have an open abdomen, then that heat is moving to the walls of the theatre. Actually, it's not important the air temperature, but it's the mixed physical object. So if you can keep the theatre warmer, the actual structure of the theatre becomes warm and may reduce radiative heat loss. Additionally, in theatre, we may hopefully have the privilege to use forced warm air blankets, such as the bear hugger, so they push warm air around the patient to try and reduce the incidence of hypothermia, or the heated mats that are more commonplace. Finally, we'll just think about the body composition of the geriatric patient. They have a reduced muscle mass, which causes an overall reduction in total body water, and they may have a higher percentage of fat tissue. There are two ways in which that might affect your anaesthetic. First of all, if there's less body water, if you give a dose of drug to an animal, there is less volume of water for that drug to dissolve into, and therefore the concentration within what body water remains will be higher. So you may see a relative overdose in these patients. Additionally, drugs which are lipid soluble may sequester within this higher percentage of fat tissue, leading to drowsy and prolonged anaesthetic recoveries. So how can we prevent this? There are a couple of ways that you can try to avoid excessive effect of the drugs. First of all, we can consider using shorter acting drugs, because even if their effect may still be prolonged, but if it's being prolonged from a half-hour duration to a 1 hour duration, that's not as clinically detrimental as a drug which normally lasts 6 hours being prolonged to last 12 hours. And we can consider infusions of short-acting drugs or intermittent boluses if syringe drivers are not available. We can consider an initial dose reduction. Remember that we can always add additional drugs at a later stage if necessary. Once we've given them to the patient, it's difficult or maybe impossible to remove those effects depending on the drug. So for example, when you're pre-medicating the older animal, maybe give half of what you would to a younger animal in the first instance, assess the effect, and give the remainder of the dose if you deem that is necessary. Bearing in mind we should always try to have a multimodal approach to anaesthesia and pain relief, because the drugs often act synergistically with each other. So we can use these smaller doses and still achieve the same clinical effect because of synergism. We can also consider increasing the dosing frequency. So perhaps with longer acting analgesics, the pharmacokinetics are often done in young healthy animals. And so say for example, we consider that we give buprenorphine every 6 hours. But perhaps in an older animal, they take longer to break down this drug. So we may consider increasing to every 8 hours the dosing frequency. But it is, of course, very important that when we are changing these dosing frequencies, particularly of the analgesic agents, we need to be able to very closely monitor pain assessment so that we don't extend that frequency too much. And finally, where possible, we should consider using local regional anaesthesia. Here, a very simple block for dental extractions, which may be a common procedure undertaken in geriatric patients. That provides the gold standard analgesic and has little to no systemic effect. So even if the metabolism of that drug is prolonged, you're not going to see an increased recovery time from the anaesthetic. So overall, I think the reason that most animals, the older animals, are predisposed to these things is because they have a reduced reserve function. So all of the body systems that we have discussed just now they perform their job, and when stressed, they have this little bit extra that they can rely on to keep the animal within a normal physiological position. However, as the animal gets older, we begin to lose this reserve function, so there's less tissue to rely on, or sorry, not less tissue, but less ability of the organ to rely on in the case of extreme stress, which anesthesia and surgery, of course, cause. So, again, just to highlight the main problems that you might encounter in anaesthetic needs patients are going to be hypotension, hypercapnia, hypoxemia, and hypothermia. They may be increasingly sensitive to normal drug doses, and those drugs may have a longer effect. So if we bear these in mind, we can try to plan to deal with these problems before they occur, and hopefully that will mean that your animal is not at an excessively increased risk of anaesthetic morbidity or mortality. So that's everything for this webinar. I hope that these points have been explained clearly. Just thank you for listening. As I say, my name's David. I'm working as the anaesthetist at London Vet Specialists. Feel free to visit our website. We offer a range of disciplines for referral of complicated cases. But yes, thank you very much for listening.